Answer the question about if I had a magic bullet, I would split it into two sets of answers. Okay, one set of answers is, I would say, what are my design credos? If you are going to be redesigning your healthcare service that you offer to patients and to families and to your consumers, your customers, you need to sort of keep 3 or 4 things in mind. One is, nothing about us without us, which is a very old phrase now. It's about 40, 50, maybe 50 years old. And it grew up in the labor movement, and it grew up related to disability care and disability rights. But healthcare, we have adopted it in healthcare in the United States to mean, don't change anything unless you consult us. If we are going to live with that process, say for example the discharge process, if the discharge process is about us, and I happen to know that, I mean, my son had 60 discharges over his life, and every day in this country 10,000 children are discharged from hospitals, usually to go home. But the process is so fraught with problems that, for example, the time it takes when they say you're going to go home versus when you're going to go home could be off as many as 5 to 8 hours. Medications are a problem at discharge. There's a lot of errors on the prescriptions, new prescriptions and things like that. So discharge is a passion of mine, trying to improve it. So, but stepping back to my design credo, if you use the principle of nothing about us without us, involve the people who are going to receive the process, ask them or try to understand what worries them most about discharge. What are their biggest problems once they go home? Is it that they don't understand their new medications? So do better teaching. Start teaching earlier. Examples like that. Another credo that I love is the idea of that I am on the team. I do know myself or my child better than anyone, and so I need to be included in all aspects of the team. For example, there should be family-centered bedside rounds in the hospital. Don't make a care plan without including the patient and family. And it's simple things, but they happen for us at one hospital where we had 25 discharges and not at a different hospital where we had 25 discharges. And so that was so frustrating not to know what the plan was every day and to have someone hand us pieces of paper or tell us, well, he's going to be on this new medication, and we'd say, you haven't even spoken to us about this. How can you make a plan without involving the patient? That's just wrong. The third thing that I love is the notion of a scientific model of change that's referred to as PDSA, or the Deming cycle. It stands for Plan, Do, Study, Act. If you make a change to the way things are done, whether it's a medication or whether it's a treatment or something with nutrition, whatever it is, if you change one thing at a time, usually you have a theory about how that change is gonna, what the outcome is going to be, what the impact is going to be. And so you change that one thing, you make your plan, you do the change, but then you have to stop and study. And by that I mean, did it come out like you thought? You had a theory. Did it come true, or do you have to get rid of this medication because it's not working or it has side effects? And then what are you going to do differently next time? And we as patients, as humans, we think like this anyway. So if you in healthcare are going to make a change to the patient's care, involve the patient and teach them how to make a change and how you do one thing at a time, and watch for the results, because they'll become better historians. We will become better at being able to tell our story and say, you know, I have noticed I'm better, since my lungs are better since I'm taking this medication. We're not kind of taught to do that, so that's a way to get on the patient's side and see things through the patient's eyes. And then in general, the other category of silver bullet or magic potion, if I were to wave a wand about how I would improve healthcare, it would be in the design, and it would be to say, to always be open-minded and to even use inclusive language at conferences like design conferences or improvement conferences or even patient safety conferences. People are very open and optimistic because they use language like, how might we? That's something that trends a lot on Twitter, hashtag how might we? And it might have even been born out of Stanford MedX or a conference like that. And even just that kind of language, the we aspect of it, how might we together fix this process for your loved one? It makes my shoulders relax. It makes me feel less stressed. I don't have to constantly be on red alert that something's going to go wrong because it's an invitation to partner. And I don't think that there's anything more important in healthcare than that we are partnered with while we are in the acute healthcare setting, so that when we have to go home and continue our care by ourselves or with our family, that we feel the confidence, that we need, that we have the skills we need. Tips like teach back, where the nurse will say to you, now I just told you everything you need to know about this new medication, now you tell me what I said. We have to reinterpret in our own words, but someone has to check with us and make sure we understood it and we learned the lesson well. Those are the kinds of inclusive and partnering and collegial, collaborative attitudes and methods that we need a lot more of in healthcare.